In a Trans Kambin OLLIF, obviously I go from the left side here. I aim for pedicle of the level below and I drop it in the Kambin triangle, which is exactly that. This is not transforaminal. You don't go through the foramen. We are extraforaminal through the Kambin triangle. The problem with the rotation is that, imagine I go from the left side, if there's a vertebral body rotation and more and more and more, all of a sudden the angle that you have to take is almost horizontal, more tissue because the body is right here. And if you're not careful, instead of going through in a large rotation like this, if you're not careful, instead of going through Trans Kambin approach, you slide in and you're in the places you don't want to be. Now, as a matter of fact, this is one of those situations that if there's a huge rotation, like as you see here, like 45 degree, but even 35 degree is quite tricky. Eventually, at certain point, it's really not safe to go through the left side because of the rotation. Then I go from the other side. I still stay on the left side, but I bend over the patient, and then I go from the right side where the angle to the Trans Kambin approach is more favorable. Obviously, this is not one of your initial cases. As a matter of fact, rotation of the vertebral body more than even 10 degree, we are talking about the level 4 or level 5 soft transition, meaning you have to have some good amount of number of the cases under your belt. You have to be feeling very comfortable with the approach, trajectory, and the instrumentation before you try the rotation. Scoliosis, I used to, when there's a big scoliosis, I used to go from the side that's open, but now with experience, even in the most collapsed, I still can get from the left side, and then I can decide, put the cage here, or put the cage all the way to the other side. By putting the cage from side to side, I can correct for so-called coronal deformity, and with a technique that we call prone lateral or MIS DLIF, MIS direct lateral in the body fusion, we don't go through the Kambin triangle. We go through the psoas, and then I can put the cage directly almost on the epiphyseal ring in the anteriorly through the psoas muscle, and then correct for sagittal deformity. And but it's important to know this surgery, the prone is a prone lateral, meaning patient is prone. I don't have to put the patient on the side, and certainly the profile of the disc is not as like a regular XLIF or lateral disc, meaning that I don't have to have a huge opening that impede with all the lumbosacral plexus here. As we know, every nerve comes out and joins the lumbosacral plexus, and by the time you get to L4-5, there are almost nerves everywhere, and 5S1 is direct lateral not possible. 4-5, high rate of nerve problem, but even in L4-5, 5S1 or MIS DLIF in prone is possible because exactly that we don't have a large cage profile that would just punch itself through all the lumbosacral plexus. The risk profile of our prone lateral or MIS DLIF is the same as the OLLIF, and that enable us not only if we want to correct for deformity much better, but as well use that technique in the L4-5, 5S1. In the L4-5, 5S1, I always try first use the iliac crest as my guide, then hit you feel that bump here. Then use the ala as my guide and go in, but if there is a huge bone growth here and that is completely obscured, I go a little more lateral. Again, I use the iliac crest as my guide, and then I am anterior to the nerve root and not in the Kambin triangle, and I perform a direct lateral fusion in prone on practically on L4-5, 5S1 all the time. And we have published that paper almost 7 years ago. Thank you.